Welcome to webinar number 4 in the series Pathways and Diagnosis. If you weren't able to join us for the previous webinars, this series was formulated to help you all learn how to incorporate the spectral domain OCT into your practices to its maximum potential. We went through various diseases and we talked about how you can use the OCT. We went through all of the different capabilities that the machine can do for you and how it can help you become a better diagnostician and help you manage disease better using this technology. It's not a standalone technology. We talked about how you have to use it in company with all of the other testing that you usually do, but we want to maximize its use and we want to provide almost a rubric or an outline that you can take back to your practices to follow when you're using OCT. So this particular presentation is going to talk about glaucoma. How can we use SD-OCT in the management and diagnosis of glaucoma? So really the question is, what does the OCT provide for us that we wouldn't get on a normal examination? The OCT provides excellent information about the retinal nerve fiber layer and also the ganglion cell complex. And the ganglion cell complex is a huge topic right now in glaucoma because, as we know, the ganglion cells feed the optic nerve, so any problem with the ganglion cells is going to affect the nerve and potentially cause an optic neuropathy. So we're going to talk about how the OCT can give us a printout on all this information, how we can use it in early diagnosis, and how we can learn to manage patients over time using this technology. So this is the slide that I kind of followed through on each of the presentations because I want to emphasize the importance of understanding how to interpret an OCT, because if you don't understand this, you can't look at a scan and recognize normal from abnormal. So essentially an OCT is a non-invasive test that we use. It's like a camera. We put the patient behind it and we can acquire images in 3 to 6 seconds of whatever we want. It's a test that uses light waves to obtain a tomographic or cross-sectional image of the retina. So on the upper right, you can see what an OCT looks like, what the printout, the cross-section looks like. And the black hollow space on top is the vitreous cavity. And then you can see our inner retina, which is your nerve fiber layer, your ganglion cell layer, your inner plexiform and internuclear layers. Then your outer retinal tissue, which is your outer plexiform and outer nuclear layers, your external limiting membrane, your ISOS junction, which is the junction of the photoreceptors, the inner segment, outer segment junction, the retinal pigment epithelium, which is a nice boundary to look at because of that hyperreflective red color, and then obviously your choroid, which is all the way on the bottom. The picture on the bottom of the screen or of the presentation shows how the OCT correlates histologically with the layers of the retina. Okay, so if you see an abnormality on the OCT, you can go back and look histologically and compare, oh, that's, the amacrine layer or whatever, so you can compare. And you can actually use this slide in your office. You can put this up and you can go back and try to find the layer where an abnormality occurs. So it's important to keep this in the back of your mind as we move through the presentation. So a crucial part of all of these webinars, which I'm trying to emphasize as we move through them, is that we want to use our technician to their maximum ability. Okay, we want to train the technicians to obtain all of the information that we need so that when we go in and see the patient, we don't have to go back over all of the things that could have been done before we came in. Okay, we need to train the technician to obtain the information that's necessary for the disease condition that we're looking for. So a patient that we're working up for glaucoma would have a different evaluation or history than a patient that perhaps had AMD. Okay, so training the technicians to their maximum capabilities and potential is huge in this whole process. This is kind of a flow sheet that I like to show the students at NOVA because I say to them, this is what we need to be thinking about in patients that present with glaucoma. There's certain parts of their history that really are crucial in leading us in the right direction in the examination. The first thing is ocular surgeries. Okay, a lot of patients don't know what they've had. They said, yeah, Dr. Rodman, I've had something, I'm not sure what it is. But a lot of these things you can actually notice when you're looking at them behind this lamp. But you can ask them, was it an LPI? Was it a trabeculoplasty? They probably won't know. But these are the things that you kind of want to look for. And of course, depending on the type of surgery that they've had, that's going to help us determine what kind of glaucoma they had, right? If they had an LPI, we'll worry more about a narrow angle, right? If they had an ALT or an SLT, then they probably had an open angle, okay? If they had a shunt or a trabeculotomy, then they probably had more of an advanced glaucoma, okay? So these are important things that you want to obtain in your history before you even see the patient, okay? What about ocular traumas? A patient that has a unilateral glaucoma, that's a really important question to ask. Were they ever hit in the eye? Did that ever result in angle recession? Do they have synechiae, which might be an indication that there was some old traumatic experience in that eye? And that would put them into that category of more of a traumatic glaucoma than an open-angle glaucoma. What about medications that they're taking? We all have heard of the steroid responder. We want to make sure that the patient doesn't have a long history of taking steroids, right? That can cause the intraocular pressure to rise. Nasal inhalers, those count too. Okay, so those are important that we ask. A lot of patients don't think about those types of medications as being dangerous for them, but essentially they could be. Okay, they could have bad side effects for the eyes. And that would put the patient into that steroid-induced glaucoma category. Okay, so this helps us to kind of isolate the type of glaucoma that we're looking at. What about the refractive error? High myopes have a larger axial length and tend to be more at risk for developing the primary open-angle glaucomas. Okay, so that should be, again, in your arsenal of information that you're obtaining when you do the history or when your technician takes the history. What about the patient's medical history? Risk factors that put a patient in risk of normotensive glaucoma versus an open-angle glaucoma, right? So some people don't believe in normal tension glaucoma, but even if you don't believe in it, if the patient doesn't have high pressure, but they have optic neuropathy, then we need to think about these particular risk factors, okay? Cardiovascular risk factors. What happens when they go to bed at night? Does their blood pressure drop? Do they have nocturnal systemic hypertension or hypotension, meaning that the blood pressure drops? Well, that would cause poor perfusion to the nerve and potentially result in a normal tension situation. What about a high cholesterol or diabetes or a microvascular disease that results in poor perfusion to the nerve? What about a carotid artery problem? Right? The carotid artery feeds the ophthalmic, feeds the central retinal. What if there's some kind of blockage there? The patient's not going to get the blood supply that they need, and they may result in a normal tension glaucoma situation. Hematologic disorders, a hemodynamic crisis. Did they ever lose a lot of blood? A hypovolemic syndrome, okay, which would lead to ischemia. Hypercoagulable states. Do they have trouble with blood that's too thick or too thin? Okay, so these are all situations where the perfusion to the nerve may be affected, and we need to think about those things in normal tension glaucoma. And then the last one is a vasculopathic situation like a migraine. So it's been proven in the literature that patients that have migraines have worse perfusion than the regular population. So that's another person that might be at risk of developing normal tension glaucoma. What about primary open-angle glaucoma? What would put a patient at risk? Are there risk factors? Well, certainly it's familial, right? It runs in families, which we're going to talk about in a minute. Older age is certainly a risk factor, okay? We talked about microvascular disease in the sense of normal tension glaucoma, but it's actually a risk factor for primary open-angle glaucoma as well. Any history of eye diseases, trauma, again, steroid use, things like that can put a patient at risk, maybe not for a primary open-angle glaucoma, maybe a secondary open-angle glaucoma. Okay, so these are things, again, that we need to consider when we're doing the workup of these patients. Once we've obtained a very good and thorough patient's personal history, we want to go on to the family history. Because glaucoma is one of those diseases, not all of these that I'm presenting in these webinars go into this category, but this is one of these diseases that actually does run in families, right? We know that if a patient has a brother or sister that has glaucoma, they're at a very high risk of developing the disease themselves. If a patient has a mother, a father, an aunt, an uncle, they're still at a very high risk. So we want to get a very good history about what's going on in the family if we can. Once we've obtained all of our history, it's time to start getting all of the screening information. So the screening OCT is the first step that we take, that we have our technician help us with as far as testing goes. And I emphasized in the previous webinars that you can use any type of instrument that you want. It could be an OptiView, it could be a Cirrus, it could be a Heidelberg Spectralis. But the most important part is that we want to make sure that the OCT has all the information on it that we want. We want to have some type of assessment of the retina, the retinal thickness, the ganglion cell complex. Okay, so here we have a printout of the OptiView, the eye wellness printout, which I particularly like because it has everything on it in one printout. You don't have to go and obtain multiple scans to get all the information that you need. So I'm going to run through this printout quickly, because once you understand how to interpret this image, you'll understand how to interpret most images that come out of these machines. Let me actually go back here. Okay, so on the top here you can see that those are the B-scan images, or the cross-sectional images of the retina. Okay, that gives you just the regular cross-sectional image. On the bottom left, we have the full retinal thickness scan, which gives them, on a micron scale, the thickness of each layer of the retina. In a normal patient, it would be green just like this. Then we have the ganglion cell analysis. The ganglion cell analysis gives us an interpretation of the ganglion cell complex, which we're going to go into more detail. And you can see in this patient that there's that red area on the left eye, which indicates that there's something going on with the ganglion cell complex. There's an area there that goes outside of the norm in this patient. And again, I'm going to talk more about this printout in just a moment, but let's look at what the cirrus would look like. Okay, so in the cirrus, we have to obtain two images, two separate printouts, because not everything is on one scan. On the left-hand side is your interpretation of the nerve and the peripapillary area, and then your ganglion cell information is on the second printout. So just to kind of go through quickly what you have on each printout so you understand, on the nerve fiber layer printout, the images on the top show kind of a tomographic image of what thickness is on each part of the peripapillary area. What we would expect is that inferior and superior, the tissue would be the thickest, and that's actually what those warm colors coming off the nerve indicate. So that red and yellow coming off the nerve, superior and inferior, is what we want to see. You can see that in the right eye, but not in the left eye. Then you have your nerve fiber layer T-SNP map, where that should, again, correlate. You should have a double hump. The lines should go up, inferior and superior, correlating with that area of thickness that you would anticipate in those sections. And you can actually see here that your right eye is more thick or healthy than the left on those T-SNP maps. It compares with a dotted and a stronger line, a not dotted line, the two eyes. Then you have your hemispheric analysis, where it shows you each section and how that section corresponds to the population. And then it obviously gives you your 3D optic nerve head cuts, where you can see the nice contour, the round U shape of the optic nerves. So it gives you a lot of information on that one printout. And then on the second printout is our ganglion cell map. If you were with us for the previous webinars, I talked about how you want to see a nice green donut around the black center that doesn't have ganglion cells, the fovea. You can see here in this patient that there's not a nice green donut. In fact, it's more red or yellow. It's a little bit outside norms. Okay, and then it shows you the statistical significance lower down on the map. So again, either printout is fine as long as you're comfortable with how to interpret them. So back to the OptiView, I kind of went through this before, but we had our B scans on top. We had our retinal thickness maps on the bottom. The blue here shows that that area is thinner than the normal population, more outside of the normal statistics for that patient. And then your ganglion cell complex. This area here, this red, again, shows you that there's an abnormality in that superior area. So this would be an eye that's being tagged essentially as abnormal. And if you're suspecting that it's glaucoma, then this ganglion cell map is giving us some excellent information. Why is the ganglion cell map important in glaucoma? Okay, what is all the hype about it? Well, we know that the ganglion cells are housed in this area in the ganglion cell complex, and the ganglion cells are made up of dendrite cell bodies and axons. So if there's essentially an abnormality of any of those features, the ganglion cell complex is going to be abnormal. So in a patient that has a glaucoma, or really any optic neuropathy, it wouldn't be abnormal to see an abnormal ganglion cell complex. So if we go back to this previous slide, this image on the bottom is telling us something about this patient's eye. It may be about the retina, but it really might also be about the optic nerve. Okay, so now we have some preliminary information on the OCT. We saw that the right eye in this patient looked fairly normal, but we saw that the left eye had an abnormality on that ganglion cell complex, and that's something that we're going to want to investigate in more detail. Okay, we want to make sure that we don't miss anything because the machine is picking up on something for us. So now we have the technician go ahead and obtain some non-dilated fundus images, okay, because we want to stack those side by side with the OCT. So here we have the fundus images of this patient, and just on quick glance, those nerves don't look too glaucomatous to me. In fact, the CV ratios look pretty equal between the two eyes. But again, the OCT is showing us something, and we can't ignore it, okay? In fact, the repeatability on these eye wellness printouts are pretty darn good. So if we were to go back and do this again and thinking maybe that's an artifact, the probability of this defect coming up again is pretty high. So what do we do next? We go ahead and we get some visual field testing, right? We want to make sure that our OCT, which is showing structural damage, corresponds with functional damage. The visual field shows us how the patient is functioning. Okay, how does that structural problem on the GCC correlate with the patient's vision? Maybe the GCC, or the damage that we saw structurally, is showing up earlier than the patient's functional deficit. Or they may be coming hand in hand. There's no rule for that. So we need to look at it and assess how significant the problem is. Here's the patient's visual field. And essentially, what can we see? That the patient does have an inferior defect that correlates perfectly with that ganglion cell loss superior. So now we can see that this patient has a structural defect and a functional defect. And this might actually be somebody that you want to be more aggressive with because they already are showing evidence of functional change. Now it's your turn, okay? You've obtained all this information from your technician, okay? You're stacking fundus photos. You weren't so impressed with the optic nerves, with the damage on the ganglion cell complex, with the damage on the visual field, and now it's time to put them behind the slit and try to make some decisions about how we're going to deal with this patient. So the slit lamp exam in glaucoma is crucial because there's so many parts of it that are important. The first is obviously the intraocular pressure. Okay? Is the patient doing well? Are they on meds? Are they compliant? Okay? Is their pressure at the desired level? So we're looking for normal, we're looking for abnormal, high, low. Okay? We're looking at the angle assessment. Okay? Important to look, is it an open angle? Is there evidence of trauma? Is it a narrow angle? Are there synechia? Is there pupil block? Is there a plateau iris? So being good at gonioscopy is very, very important in patients that have glaucoma because you can miss something that's going to really alter the way that you take care of the patient. So we're going to do gonioscopy, and on the next slide I'm going to show you how you can incorporate OCT into a workup of the anterior chamber. Okay? We can use OCT to determine how deep or how shallow the chamber is. Okay, and we'll look at that next. What else do we want to look at in the anterior chamber? Any evidence of pigment anywhere? Are there Krukenberg spindles? Are there translumination defects? Is there any indication that this might be a pigment dispersion situation? Is there pseudoexfoliation? Is there pseudoexfoliative deposits on the zonules when you do gonioscopy? Okay. What else do we want to get? We want to get pachymetry. And again, we can utilize the OCT to get the pachymetry. So here you can see on the left how the OCT will look with a pachymetry reading. Okay? You get a scan of the cornea, and the machine will give you a printout of the thickness at every single level. So if you're looking at central corneal thickness, this one's somewhere in the 530s, that would be pretty good. 550 is normal. Okay? And then on the right-hand side, you can see what an angle assessment looks like. If you place your crosshair at the limbus, the machine will automatically draw out the angle for you. You can see the endothelium and the ciliary body band, and somewhere in the middle there is your angle. Okay? And the machine has a ruler or a caliper that you could actually line up and measure that angle. So we are looking for something, at least on this machine, greater than 20 degrees, which would indicate to us that this angle is open. So this is really utilizing your OCT to its maximum potential, because most people have it and again don't think of using it for pachymetry or anterior chamber. It's really just for retinal and glaucoma scans. Then we move on to the fundus examination. Okay? And again, we said before when we looked at this patient, we weren't so impressed that the optic nerves looked too different. Okay? They're moderate sized. The peripapillary tissue looked fine. There wasn't any obvious neurofiber layer defects, wedge defects, notching. Okay, overall, this looked pretty good. However, we have to keep in mind what we found on the visual field and the ganglion cell complex. So now is the opportunity to go back into the exam and obtain all of the specialized testing that you want to get. Okay, we already got the screening testing. Now we want to use the machine and actually hone in on the areas that were abnormal. So we always start off with our 3D optic nerve head because it gives us excellent information about the peripapillary space. Are there elevations, are there depressions for any reason in the peripapillary space? This is a normal printout. Okay, you get that normal U-shaped dip at the optic nerve. Any elevations or depressions would change that contour and make it look different. So essentially in this patient, the optic nerve looks fine, the contour looks fine, the pit looks fine. We're going to veer off of the example patient and we're going to go into a different patient that actually has pretty significant glaucoma here because I want to go over with you how you would assess the nerve fiber layer in a patient that really has glaucomatous changes. So here you can see on the right hand side a 3D optic nerve head photo of a patient that has significant glaucoma. And you can see there's significant notching of the neuroretinal rim tissue, inferior temporal, in fact, all the way around the inferior. How would that correlate? How would that look on a nerve fiber layer assessment? So if you look at the printout on the left-hand side, that's what the RNFL assessment will look like. The ring around the outside shows how statistically significant each area is on the rim tissue. And this is showing us that in the superior quadrant, superior temporal, it's normal. What happens inferior and inferior nasal, at least on this printout, it begins to veer outside of the norms. You can see the coloration, the yellow and the red, is showing us that on a statistical significance scale, it's outside norms. The tissue on the inside, around the cup and disc, is that thickness on a micron scale. Okay, so that's where we'd be looking for elevations or depressions. Remember, we talked about the inferior and superior having the greatest amount of tissue. We would expect some redness or yellow coming off of that cup and nerve, and we don't see that here because this nerve is so cupped that it's just missing the normal, healthy, robust appearance that we would expect. And that correlates with the T-SNP map on the bottom. Again, expecting a double hump, we're not seeing that on that inferior nasal inferior side. It actually gets pretty flat, indicating an absence of the neuroretinal rim tissue there. And that correlates with that statistical significance on top. So you can see how the picture directly correlates with the nerve fiber layer assessment. And it confirms what you can see on the stereo photo. What is the GCC going to look like? Okay, the GCC is going to pick up maybe different things than the RNFL. It might pick up information that we didn't see early on. Okay, so here again is a picture of that nerve and what the ganglion cell complex would look like. Okay, the one on top, all the way on top, is what normal should look like, right? That green donut around the fovea. We're clearly not seeing that in this patient that has significant glaucoma. Okay, so we can see the thickness map here is showing us an absence of that nice green color, right? It's almost black or navy, indicating thinning. See the micron scale there on the side, it's showing you that that area is thin. The ganglion cell complex is thin, it's not healthy. And then how does that correlate on a significant scale? It's way outside of norms. That's what that red is showing you. The red is not showing you thickness. Remember, you have to look at the scale on the side of the picture. That red is showing you that that area on the thickness map that's black is way outside the statistical norms for this patient. So the GCC is giving us some good information. If you recall, if you look at the photo, you can see that that area inferior temporal, again, is the area that's being tagged on the GCC. So it all correlates. The superior GCC looks much better than the inferior GCC. What is the hype about FLV and GLV? So this is actually a function that is only on the OptiView machines, but I think it's worthwhile to talk about because there's been a lot of literature published on it, and it's actually a very, very useful tool in glaucoma. FLV stands for the focal loss volume. GLV stands for the global loss volume. What does that mean? The focal loss volume looks at areas of focal loss, areas of abnormality on the GCC compared to the entire picture. So if you were to think about this as a pizza, how much of the pizza is red? And it gives you like a percentage or a number. There's so much red over the green. Okay, obviously the higher the number, the more abnormal the FLV is going to be. The GLV is the global loss volume. It looks globally. It doesn't look for focal defects. It looks overall at the whole picture. It's almost like looking at the mean deviation on the visual fields. It compares the patient to the normative database. So both of these in this patient are outside normal limits. What does that mean? What does the literature tell us? How can we use this information to make a decision about how we're going to treat this patient? So these slides have a lot of graphs, and I hate graphs, so I'm going to just talk you through it because the numbers are pretty easy to remember. If you have a patient that has a GCC FLV that's borderline, let's actually start with the normal. If you have a patient that has a GCC FLV that's normal, okay, it's green, that's the line on the bottom, they only have a 10% chance of converting to glaucoma. Okay, so I almost feel like saying they're safe. But if you have a patient that doesn't have glaucoma and their FLV is abnormal or borderline, they have a 41% chance of converting. So this slide talks about patients that don't have glaucoma yet. It's a conversion slide. If the FLV is normal, you have a 10% chance of converting. If the FLV is borderline or outside normal limits, you have a 41% chance of converting. That's huge. That's almost half the patients. So somebody that is a glaucoma suspect that you do this test on and you find a red or yellow FLV, that's somebody that I would highly consider treating or really monitoring closely based on this conversion rate. What about the GLV? Actually, the FLV in progression. The first slide was on conversion. This one's on progression. So here's a patient that already has glaucoma. How can these numbers help us determine if they're going to progress? Okay, so what if it's normal? If the FLV is normal in a glaucoma patient, they have a 30% chance of getting worse. If the FLV is abnormal or borderline, they have a 60% chance of getting worse. So the patient that we just looked at a few slides prior had a red FLV. He already had glaucoma. That means he has a 60% chance of getting worse over time. And you can see how the percentages go up over as the years go on. So those numbers are very important. And this machine gives that information for you, and it's almost like a premonition or a crystal ball of what's to come in the future for the patient. What about the trend analysis? We know that on the Humphrey visual field, we can use the guided progression analysis, which gives us great information about how the patient's doing over time. What can the OCT do for us? Well, the OCT also has a trend analysis. Here's a patient. You can see their GCC on the top of the printout. You can see how the coloration looks kind of stable. There might be a little bit of worsening of that navy color on the side of the image, but for the most part, it looks pretty stable. You can look at the nerve fiber layer. You can look section by section at each number and compare. But if you don't want to think about anything, the machine will do it for you, and that's what those graphs on the bottom are. The one on the left shows you RNFL, the one on the right shows you GCC, and it shows you that if the patient were to continue on the course that they're doing, their glaucoma would continue to get worse. Even though it's a very small slope, it's not a stable slope. It's not a plateau. So this change analysis is excellent because this patient's come back 4 times, and you can see from baseline to the most current exam how they're doing. And you may want to change treatment based on these parameters. Now that you have all the information, I'm going to run through this rubric that I presented and talk about what we did and then show you some examples. So here we had the technician start with the patient's personal and family history. We got all kinds of information from them about prior surgeries, refractive errors, medications they may be taking, systemic risk factors, family risk factors. We got a screening OCT that on a patient that really looked pretty normal based on stereo photos, we found that the GCC was abnormal in one eye, and that corresponded with a functional defect. That might have been something that we wouldn't have done anything with if we were to look at that patient without supplementary testing. So these instruments helped us pick up a lesion much earlier than we would have. We did slit lamp. We looked for Krukenberg spindles and any evidence of iris transillumination or pseudoexfoliation or a narrow angle or any of the secondary glaucomas. We did pachymetry on the OCT. We did anterior chamber on the OCT. We obtained some high definition images, and we looked at the RNFL in detail. We looked at the GCC in detail. We talked about the FLV and GLV and how they can help guide our exam based on the probability statistics. And then we made a game plan for the patient. So the patient at the beginning that I presented, that was just someone that came in for routine exam, we may have started treatment or may watch them a little closer than we would have if we didn't have the ancillary testing that we used. So back to the patient from the beginning, there was that GCC, there were the photos, and what would we do? I would probably start a monocular treatment trial on that left eye, because if I look at the FLV and GLV, which were red in this patient, that tells me, remember the conversion rate on a patient that doesn't have glaucoma, they have a 41% chance of converting. So it's, you can play your odds if you're a statistician. You can watch or you can treat. All right, so here's a case example of a patient that I saw at Nova in the clinic. This was a 66-year-old white male who comes in for a comprehensive eye exam. His medical history is normal and his ocular history are normal, but he has a family history. His mother has glaucoma, and we talked a lot before about how glaucoma runs in families. It's a genetic disease, okay? You can see everything looks pretty normal, but the pressure in his left eye is high, and his pachymetry is normal. So really the only thing that we're looking at in the exam right here is the 26 millimeters of mercury in that left eye. We get the screening OCT. We can see here that the B-scan images look normal, but the GCC is a little abnormal. And you can substantiate that by looking at the FLV. It shows you that it's red. Okay, so if you were thinking maybe it looks okay, look at the FLV and you can see that it's abnormal. And you can also see that the retinal thickness map's abnormal there that correlates with the GCC. So recall, in a patient that does not have glaucoma, get this number in your head. If the FLV is abnormal, there's a 41% chance of conversion. Okay? So this map, before we even do anything on the patient, has given us some excellent information about the prognosis or the risk factors involved here in this patient converting to glaucoma. We get some OCT photos. Okay? Looking at them, clearly the optic nerve head sizes are a little bit different. The right nerve looks a little bit bigger than the left, but I'm not impressed, again, that the cupping looks too different here. Cupping looks pretty symmetric. It's just that one eye is smaller than it, one nerve is smaller than the other. But you have to keep in mind that that FLV is abnormal and that GCC is picking up something. So we run the visual field. Remember, we want to find out if that structural problem on the OCT correlates with a functional problem on the visual field. The right eye looks fine, which we would anticipate, at least based on the screening OCT. But what does the left eye look like? Left eye's got some random defects. I wouldn't look at that field and say, gee, I'm concerned. I may repeat it, but I don't even know if I would repeat it. There's some random scattered defects, nothing that's really significant to me. Okay, so you start to ask yourself, is the GCC picking up something structurally before the functional part comes out? And essentially in this patient, yes, it did. Then we run some more specialized OCT testing. We get the GCC on the specialized testing with the RNFL, and we get everything on one printout. So on the top part, on the right eye, the GCC looks pretty normal. There's some patches of yellow and red there, but the machine is not telling you that those are two outside norms because they're not being tagged on the FLV and GLV. The FLV and GLV on the right eye are normal. Let's focus on the GCC first. If you look at the GCC on the left eye, you can see that there's more abnormality, more patches of red. And in this particular eye, the FLV and GLV are both being tagged as abnormal. So it is going along with what the screening exam showed us. The RNFL, though, it looks fabulous, right? There's no evidence of any abnormality on the RNFL. It's nice and green. We can see the thickness, of course, the T-SNIT on superior and inferior is better thickening, which is what we expect, so that looks fine. But we need to run our eyes back to that FLV and GLV because of that 41% chance of conversion. So what are we going to do now? We're going to look at a trend analysis. So let's say we saw the patient. Let's go back to this slide. We saw the patient here, and we decided, you know what? There's no functional loss. The nerves look symmetric. The pressure was 26, but we're going to watch them. Okay, let's just say we did that. There's no right or wrong answer. Let's say we decided we're going to watch them, we're going to bring them back in 6 months to a year, okay? And then we bring them back in 6 months to a year, and here's your test to see if you made the right decision. Because in 6 months to a year out, the machine is showing you the GCC, I showed you this before, it's showing you the significance maps, and it's showing how each aspect of the printout has changed. And if you look at the bottom section, it shows you that over the course of 2.5 years, both the GCC and the RNFL have showed evidence of change. Not major change, but change. It hasn't been 100% stable. And the picture with that line that kind of goes down is showing you in kind of like an anatomical way that it has dipped. So now, even though you didn't treat the patient initially, now's your opportunity, because there hasn't been that much damage. Remember that glaucoma is a slow-moving disease in most cases. You can treat this patient. You can say, okay, I have substantive proof. You may want to repeat the visual field and see if the visual field correlates with this. But this would be your opportunity to treat the patient. Okay, and we go back and we look at the nerves again, and we still don't see asymmetry, maybe a little asymmetry, not enough maybe to correlate with what we're seeing, but we have enough proof here that we want to initiate some treatment in this patient. So the summation on this patient is that there's that family history. If you recall, the mother had it, and that is a significant risk factor. There was an abnormal GCC on the screener. The patient had elevated intraocular pressure in that left eye, which, by the way, remained slightly elevated over the years until we initiated treatment. It never went above 26. The patient had slightly asymmetric optic nerves, nothing that I would look at as totally alarming, right? It was very subtle. The specialized OCT testing confirmed an abnormal GCC, abnormal FLV, abnormal GLV in that OS. And there was evidence of change on the change analysis. So in this particular patient, even though there was minimal detectable functional damage, there was evidence of early change that the OCT was able to pick up for us. And so we initiate treatment in this patient. And again, you may decide that this is not a patient that you want to treat, and that's fine. But the purpose of this example is to show you how the OCT was able to pick up on something earlier than the visual field did. And it told you that based on the literature and based on statistics, this patient had a pretty significant risk of developing glaucoma. Here's another example. A 40-year-old Hispanic female. She comes in for a comprehensive exam. She has reduced vision in her right eye for a month. This was an extremely interesting case. She has a sister with glaucoma, so when she started having decreased vision in that right eye, her initial thought was, I have glaucoma, okay? Because people know what's in their families, and they worry. So her vision in that right eye was 20/30, which correlated with what she was noticing. She was a -4 myope. Everything was pretty normal. Her pressures were normal, her pachymetry was normal, but she did have that reduced vision. So we ran an OCT, okay? If you look at the RNFL layer, it looks fine. Okay, there's no evidence of abnormality on the RNFL. Nice green. You can see the thickness, inferior and superior, on the micron scale and on the T-SNP map. It matches perfectly what we expect. Look at the GCCs. The GCC in that right eye is showing us an abnormal area. It's showing up red there, okay? The left eye, it's not. If you look at the left, even though there's some a little bit of yellowing there, the machine is not telling you that it's so outside norms, but there is something going on in the GCC on that right eye. So then you look at the nerves and you say, gee, the nerves definitely look large, right? The cupping looks large. Are they glaucomatous? Hard to say, but we do know that the FLV is red in that right eye, and we have it stuck in our head now that there's a 41% chance of conversion. We look at the nerves again, okay? They're big. Overall, they're big. Not only is the cupping big, but if you're really good at looking at optic nerves, the nerves themselves are huge. The left eye is even bigger than the right eye, but they're very large. She's a myope, remember. Myopes, by definition, have larger nerves than hyperopes. So was she allowed to just have large nerves and large cups, but the FLV was abnormal. And the machine takes into account the size of the nerve. So not all the puzzle pieces are going together, because if the patient just had large nerves, the FLV wouldn't be abnormal, okay? And the machine substantiates the fact that the nerves are large. It tells you that the cup in the right eye is 2.89 and the cup in the left is over 3. In a Hispanic female, maybe 2.7, 2.8 might be the largest that we would anticipate. Even smaller in a regular Caucasian individual. So this patient definitely has megalopapillae, but let me stress to you that in megalopapillae, everything has to be normal. The visual fields have to be normal, the RNFL has to be normal, the GCC has to be normal, and that's not the case here, right? She has an abnormal GCC. So we can't ignore that. So what do? We start treating her, but wait a minute, we forgot one thing. Let's do her visual fields. Are they normal? Well, there's something showing up on the left eye, okay? Is it glaucoma? Don't forget, though, to beware of retinal conditions. We talked at the beginning of this lecture and in the prior webinars that the GCC doesn't only correlate with optic nerve, it correlates with retinal conditions as well. Remember, inner retinal conditions. So let's look at her fundus, okay? What do we see? Whoops, we found an area of exudation there with significant swelling in that eye, okay? So that's why she was complaining of decreased vision. Right? She had 20/30 vision. Her nerves were huge, but they didn't show any evidence of glaucoma. The visual field was essentially clean, but the FLV kept ringing in our heads. We can't ignore that. But now when we look at her retina, it makes sense why the FLV was abnormal, because she has a retinal condition that can make that FLV abnormal. Okay, so this case is called beware of the retinal conditions. Because if you didn't look at her fundus and you just looked at the disc photos, you would have started treating her based on the FLV and based on the percent conversion rate. But once you look at her retina, you can see that there's something more going on than just megalopapillae. And here's that point again, all right, that the GCC can affect the inner retinal tissue. So the summation of this patient, she had decreased vision in her right eye. She had retinal exudates of unknown etiology. We ended up sending her out for a retina consult. She had large optic nerve heads, and it's okay to have large optic nerve heads, but it kind of threw us off because when the FLV was abnormal, we were thinking, okay, she's got glaucoma. But she only had megalopapillae. Megalopapillae it's a benign condition. You're allowed to have large nerves, but everything has to be normal if you have large nerves, and hers wasn't. And that's what prompted us to do additional testing and make sure that that FLV wasn't correlating with retina instead of glaucoma. So the summation here is that we referred her out. We asked the retina specialist to order some additional testing to try to figure out, and obviously they knew what they had to do, figure out, is the patient diabetic? And it turns out that this patient has exudation of unknown etiology. I still see her all the time. We don't know why she has exudates, but we do know that that's what was affecting her OCT. So the take-home message on this case is that the FLV can indicate something more significant like a retinal problem than just glaucoma. And I love this slide. This is a depiction, a typical old couple, and she says to him, I feel horrible. I look old, fat, and ugly. I really need you to pay me a compliment. And he says to her, your eyesight's damn near perfect. And I think that's just fabulous. So it's like, okay, you have all these problems, but you're looking at yourself and you see exactly what you see. So you're seeing just fine. Thank you so much.